Hello, this is Dallas Holiday coming at you today with a lecture about pain management in the emergency department. Luckily, we have a ton of tools available to us for managing pain in the ED. This lecture is going to be a brief overview of pharmacotherapy for acute pain, primarily aimed at new learners, but we'll cover some cutting-edge sexy stuff at the end. First, we're going to discuss opioid analgesia. For many ED practitioners, opioids are the cornerstone of severe pain management in the ED. Unfortunately, in the last few years, opioid addiction has been on the rise, resulting in increased morbidity and mortality. Opioids, including prescription medication and heroin, killed 33,000 people in 2015, more than ever recorded before. Currently, 91 Americans die every day from opioids. This has led to the reclassification of opioid medications as Schedule II, as well as increased physician education in an attempt to reduce opioid abuse. Most guidelines apply to prescribing practices. Acute management in the ED is at the discretion of the physician. However, caution should be exercised in light of the addiction issues. In September 2016, police in East Liverpool, Ohio, decided to release a series of images of a couple who had overdosed on heroin while their grandson was in the back seat of their car in an attempt to combat addiction. These photos were taken during a routine traffic stop after the driver was seen driving erratically. Through slurred speech, he told police he was taking his passed-out wife to the ED shortly before losing consciousness himself. Both adults were woken with naloxone from EMS. In general, the major adverse effects of opiates are respiratory depression and hypotension in the acute setting. Caution should be exercised in the elderly and patients with renal impairment, especially those on dialysis, as reduced excretion may result in higher than expected levels. Codeine, or methylmorphine, is a prodrug of morphine. Approximately 10% of codeine is demethylated to morphine by the liver in most individuals. Compared to other opioid medications, codeine has relatively little analgesia effect. Some pediatric patients have a PY450 genetic alteration and ultra-metabolized codeine. These patients are at risk for respiratory depression. Notably, codeine promethazine cough syrup became popular in hip-hop culture after 90s rapper Dr. Screw released a number of songs about its recreational use. Colloquially referred to as purple drink, the cough syrup is mixed with Sprite and consumed at levels up to 25 times those prescribed for cough and analgesia for a mild euphoric effect. Rapper Lil Wayne has openly struggled with purple drink addiction and was hospitalized for an overdose in the early 2000s. The American Pain Association recommends codeine 30 to 60 milligrams by mouth every 4 hours as needed for pain. This is commonly found in a combination preparation with acetaminophen, commonly known as Tylenol number 3. In 2017, FDA released a warning against the use of codeine in patients under 12, as well as some patients under the age of 18 with certain genetic factors, obesity, and sleep apnea. This warning includes breastfeeding mothers due to concerns about codeine in breast milk and the effects on the infant. Thus, codeine should not be used for pediatric patients in the emergency department. Caution should also be used when giving any opiate with benzodiazepines or other medications that cause respiratory depression. Next, let's talk about morphine. Morphine is a naturally occurring opioid and a commonly used medication in the ED. Morphine is a mu receptor agonist acting on the CNS to reduce pain. Although we typically think of this as an IV push medication, occasionally a patient may require analgesia before IV access can be established. Morphine can be given subcutaneously at doses of 5 to 10 milligrams as needed every 4 hours in the opiate-naive adult. Sub-Q dosing can lead to local irritation and is therefore not the preferred route. IM administration is no longer recommended due to the irritation and variable absorption. Typically, patients are going to receive IV morphine. In the opioid-naive adult, doses range from 2 to 10 milligrams IV push. This dose can be titrated as needed until pain relief is achieved or the patient develops respiratory depression, preferably the former rather than the latter. Opioid-dependent patients will often require higher dosing. Although less common, a patient may require a PCA for pain control. Typical morphine PCA dosing for an adult is a 1 milligram demand dose, but may range from 0.5 to 2.5 milligrams with a lockout interval every 5 to 10 minutes. Though if you're using a PCA, you should probably be consulting your anesthesia or your pain service prior to kicking that off. Occasionally, we may need to use morphine for pain control in the pediatric population. In infants less than 6 months, dosing is 0.025 to 0.03 mg per kg per dose, every 2 to 4 hours as needed. Sub-Q can be used. Extreme caution should be used in infants less than 3 months of age as they are more prone to respiratory depression. In older patients, less than 50 kilograms, they may receive 0.05 mg per kg per dose up to 0.1 to 0.2 mg per kg per dose every 2 to 4 hours as needed. Children greater than 50 kilograms should receive 2 to 5 mg every 2 to 4 hours as needed. Hydromorphone is a semi-synthetic opioid. Generally speaking, when choosing opioids for analgesia, morphine is first line. Hydromorphone is generally reserved for patients with refractory pain or those with opioid tolerance. Adult dosing is 0.2 to 1 mg every 2 to 3 hours as needed. Generally not recommended in pediatric patients. Next, let's talk about fentanyl. Fentanyl is a synthetic, short-acting opioid that is 50 to 100 times more potent than morphine. Fentanyl is less likely than other medications to cause a drop in blood pressure, making it useful for patients with pain and borderline blood pressure or frank hypotension. Dosing for fentanyl is slow IV push, 25 to 35 micrograms, based on a standard 70 kilogram patient, or 0.35 to 0.5 micrograms per kilogram every 30 to 60 minutes as needed for adults. Dosing for fentanyl is slow IV push, 25 to 35 micrograms, or if the patient does not have relief and side effects are minimal, this dose may be repeated after 5 minutes. Since fentanyl is a synthetic opioid, it can be used safely in patients with allergies to morphine and hydromorphone. Generally speaking, this medication is not appropriate for pediatrics. More recently, fentanyl has contaminated street heroin supplies. Due to the significant potency of fentanyl, this has resulted in a surge of opiate overdoses as many users are unaware of the fentanyl content. Next, let's talk about tramadol. Tramadol is a synthetic opioid that is often considered as an alternative to opioids since it is a weak mu receptor agonist and doesn't produce the same euphoric effects. Tramadol is also a serotonin and norepinephrine reuptake inhibitor. Dosing for adults is 50 to 100 milligrams tablets by mouth every 4 to 6 hours. Due to the pharmacology of tramadol, its use should be limited in several patient populations. Firstly, tramadol can reduce the seizure threshold, making it a poor choice for patients with seizure disorders and those on medications that reduce the seizure threshold, such as bupropion. Tramadol can also lead to increased INR, limiting use in patients on warfarin. Additionally, tramadol has some norepinephrine and serotonin reuptake inhibition and should not be used in patients on similar psychiatric medications or other substances which can cause serotonin syndrome, such as dextromethorphan. In April of 2017, the FDA released a warning against the prescription of tramadol in patients under the age of 12, as well as some patients under the age of 18 with genetic factors, obesity, and sleep apnea. This warning also includes breastfeeding mothers due to concerns about tramadol in breast milk and effect on the infant. Thus, tramadol should not be used for pediatrics. Next, let's talk about NSAIDs. Ibuprofen is a non-steroidal anti-inflammatory which works by inhibiting cyclooxygenase or COX enzymes, which convert arachidonic acid to prostaglandin. Ibuprofen is dosed at 400 to 800 milligram tablets by mouth every 6 to 8 hours. In the pediatric population greater than 6 months of age, dosing is 10 mg per kg every 4 to 6 hours. The maximum allowed daily dose is 400 milligrams, and daily use should not exceed. The maximum allowed per dose in pediatrics is 400 milligrams, and the daily dose should not exceed 40 milligrams per kilogram per day, or 1,200 milligrams. Due to the mechanism of action, ibuprofen can irritate the stomach, and long-term use can lead to gastritis and ulcers. Caution should be used in patients on chronic steroids, those with diagnosed peptic ulcer disease, and alcoholics. It should not be used with other NSAIDs. I'm a big fan of naproxen. I like naproxen because it can be dosed at 500 milligrams every 12 hours, making compliance a little easier. Alternatively, patients can take 250 milligrams every 6 to 8 hours. Daily doses should not exceed 1,250 milligrams on day 1 and 1,000 milligrams on subsequent days. Ketorolac, or brand name Toradol, is a first-generation NSAID which improves pain by inhibiting prostaglandin synthesis. Although oral and eye drop forms are available, we are most familiar with the IV formulation in the ED. Current FDA dosing guidelines are 30 milligrams IV push and 60 milligrams IM for patients less than 60 years of age. However, Ketorolac has a number of negative side effects, including nausea, vomiting, gastrointestinal bleeding, and renal insufficiency. Like many other drugs, higher doses increase the risk of these side effects. A recent 2016 paper in Annals of Emergency Medicine by Matov et al. Compared single dosing IV Ketorolac at 10, 15, and 30 milligrams IV push and did not find a significant difference in pain relief between the three, suggesting that the ketorolac ceiling may be 10 milligrams IV push. As with most medications, the negative side effects of ketorolac are dose-related, and we should give the lowest dose possible to achieve the desired effect. Ketorolac for pediatrics is dosed at 0.5 mg per kg, not to exceed 15 milligrams IV push or 30 milligrams IM. Similar to ibuprofen and other NSAIDs, this is not for use in pediatrics less than 6 months of age. Now, let's talk about everything else. First, let's talk about acetaminophen. The exact mechanism of acetaminophen is not known. It is primarily metabolized by the liver, so caution should be used in patients with underlying liver pathology or alcoholics. Acetaminophen is dosed at 650 milligram tablets by mouth every 4 to 6 hours or 1,000 milligram tablet every 6 hours. 650 milligram suppositories can be given rectally every 4 to 6 hours. IV acetaminophen can be dosed at 12.5 mg per kg every 4 hours or 15 mg per kg every 6 hours in patients less than 50 kilograms with a maximum single dose of 15 mg per kg per dose. Daily dose should not exceed 4 grams. No renal dosing is needed. In pediatric patients, acetaminophen can be given as a dose of 10 to 15 mg per kg in liquid or tablet form every 4 to 6 hours as needed for pain. Do not exceed 5 doses in 24 hours, and the maximum daily dose for peds is 75 mg per kg per day, and do not exceed 4 grams. Children over the age of 12 can generally receive adult doses. Acetaminophen can also be administered rectally, although more complex dosing regimens, EDs. Acetaminophen can also be administered rectally. Although there are more complex dosing regimen, EDs often carry suppositories in 120 milligrams and 650 milligrams. In small neonates, the 100 milligram suppository can be cut in half. Neonates born at greater than 32 weeks of age can receive IV acetaminophen 12 mg per kg every 6 hours, maximum daily dose of 50 mg per kg per day. Infants 29 to 2 years of age can receive 15 mg per kg every 6 hours, maximum daily dose 60 mg per kg per day. Ketamine has been hip in the open access medical education community for several years, and study after study has demonstrated its efficacy for treating pain. Additionally, the dissociative properties make ketamine a popular drug of abuse. I have to say, I'm pretty tempted to send some of this Etsy merchandise to Dr. Sergey Matov or the MRAP crew. The complete mechanism of ketamine's actions is not known entirely, but it is an NMDA antagonist and weak mu and kappa opioid agonist. Historically, there has been some concern regarding increased intracranial pressure with ketamine, which has limited its use in head trauma patients. However, there is little data to support this. Studies have shown that ketamine has similar and sometimes better pain relief when compared to morphine 0. mg per kg in the ED. Ketamine is an attractive choice in patients with high opioid tolerance, many allergies, and patients with low blood pressure. So how do you dose subdissociative ketamine for pain control? A lot of research on this topic has been done by Dr. Sergey Matov, who can be found at painfreeed.com or at painfreeed on Twitter. He recommends ketamine 0.3 mg per kg loading dose, followed by an infusion of 0.15 mg per kg per hour, which may be titrated to pain relief. The onset of ketamine is fast, 1 to 5 minutes, but the duration of half-life is short, 15 to 30 minutes, so the infusion is important for lasting pain control. The negative side effects of ketamine, which can result in dissociation and a quote-unquote bad trip, are directly related to the rate of administration. Even a small dose given IV push can saturate receptors. Therefore, the 0.3 mg per kg bolus should be diluted in a 100 ml bag of normal saline and given over 10 to 15 minutes. Since ketamine is typically thought of for sedation, it's important to make sure your administration and nursing staff are on board with using ketamine for pain control. Lidocaine is in the amide anesthetic family. Typically, we think of lidocaine for local anesthetic and nerve blocks. However, there is growing evidence that lidocaine can be used IV to treat systemic pain. Although this has been more commonly studied in the PACU setting, IV lidocaine has been gaining traction in the emergency department. Additionally, several studies have examined IV lidocaine in the ED setting for treatment of renal colic. A few studies have been published using IV lidocaine in the setting of renal colic and headache in the ED with positive results. Based on these studies, the safe effective dose of lidocaine is 1 to 1.5 milligrams per kilogram, slow push over 10 to 15 minutes. Safest to dilute it in a 100 ml bag of saline. So the big fear with lidocaine is the toxicity. Although the safety of IV lidocaine has been demonstrated repeatedly, lidocaine does have a very narrow therapeutic window, but this threshold generally isn't reached until you get to 5 to 6 mg per kg, and So as you can see, based on the previous dosing, we shouldn't be getting anywhere near that. Toxicity symptoms also occur in a very predictable manner. First, the patient will experience a metallic taste, tinnitus, and lightheadedness. These symptoms will continue to unconsciousness, seizure, and eventually cardiovascular collapse if the infusion is continued. Fortunately, the CNS symptoms precede the cardiovascular symptoms, as cardiovascular collapse requires almost twice the concentrations of lidocaine, providing an opportunity to stop the medication before that progression occurs. Lidocaine should not be used in patients with seizure disorder. Keep in mind that although studies supporting the use of IV lidocaine for pain control is not yet standard of care, so you definitely want to consult with your department and your administration before you start using this. That way you've got them on board in the event you have a negative outcome. Thank you so much. As always, feel free to reach out with any questions or comments. You can find me at Dallas_holiday or dallas.holiday@gmail.com. And if you'd like to do any more reading, here is a list of references for you.